Well, thank you for joining us tonight. We're happy to have this expert panelist here. We're going to be talking about all the advances in metastatic hormone-sensitive prostate cancer, metastatic castration-resistant prostate cancer, and we're also going to be talking about advances in the field that we're all excited about. My name is Dr. Chandler Park with Norton Cancer Institute. I have my friends and colleagues here. We'll start off with Dr. Zin Myint.
Hi, my name is Zin Myint. I'm a GU medical oncologist at University of Kentucky.
Hi, I'm Travis Spaulding. I'm a medical oncologist specializing in GU and thoracic oncology at Norton Cancer Institute here in Louisville.
Hi, my name is Ryan Malone. I'm a urologist here in Louisville, Kentucky with First Urology.
Hi there, my name is Vikas Singh. I'm a medical oncologist with Baptist Health Cancer Center in Louisville.
Hi, my name is Rohit Kumar. I'm a GU medical oncologist at University of Louisville.
Okay, so we're going to start off our discussion tonight and talk about metastatic hormone-sensitive prostate cancer. So whenever we have a patient that comes to our clinic, we want to kind of think about some of the things that we get started in terms of not just the diagnosis, but also molecular treatments and also molecular markers. So I want to kind of open it up to the panel here. When you have a brand new patient with metastatic hormone-sensitive prostate cancer, when do you consider genetic testing, such as somatic, germline, or any other testing?
I can start. I know that in the metastatic setting with castrate-sensitive disease, it's indicated to do both germline and somatic when you can, and so a combination of peripheral blood testing as well as on the tissue itself is obviously ideal. Biomarker-wise, there's not a lot that we're able to sort of glean in the prostate cancer space, with the exception of these genetic markers and HHR mutations for now, but hopefully in the future that changes.
Absolutely. Because what about your practice?
I completely agree with that. Every patient with stage 4 hormone-sensitive prostate cancer who walks into my office, they get germline and somatic testing. I mean, we've been trying to do it even earlier stages as well, like when they're high risk or very high risk. I mean, not only they gives us information about their prognostic options, but also treatment options. I mean, it can guide which kind of treatment we're going to pick for them.
Yeah, great point. Now, Ryan, as a urologist here that knows a lot about the prostate cancer, sometimes you have these archived tissues, and they keep them, but then the DNA might be denatured, and so what do you do in your practice in terms of tissue ctDNA or tissue testing versus maybe doing a liquid biopsy?
Well, I try to send both, and certainly if the tissue's within 3 to 5 years, we have a pretty high hit rate with getting a result. Beyond that, it's worth sending, but they won't result often. But it's always combined with circulating tumor DNA.
Absolutely. And then I think the other thing we kind of think about is, using the analogy, you have to have enough fish in the water to catch fish. Do you have a certain PSA for maybe some of these patients that you want to check a liquid biopsy, but if the PSA is like 1 or maybe 2 or 3, you might not develop any kind of mutations on that?
So we do send it, but good thing about some of those assays is they do give you tumor fraction. So there will be a disclaimer if the fraction is really low that you might not capture all the mutations. As Dr. Malone said, we do try to do the tissue biopsy, in conjugation with the liquid. So our preference is always if you have a solid tissue biopsy to run NGS on it. But if the fraction is low, it's going to be hard to capture all the mutation on a liquid biopsy. So
we're going to go ahead and switch gears, and we want to kind of talk about the changes in terms of detection of prostate cancer. A lot of the studies that we read about was done in an era where we use conventional imaging, bone scan, CT scan, but now we're in an era of molecular imaging where we have PSMA, PET imaging. We have Polarify, F18, we also have gallium, and there's some subtle differences there. One is like mass produced, the other one's actually produced close to the facility. And so they both detect cancers for treatments, but in terms of our practice, all the clinical studies haven't kept up with the high volume and the low volume, but yet we get PSMA PET scans for everybody. So Zin, what do you do in your practice? Like, let's say you get PSMA PET scan or you get a lot of second opinions. How do you distinguish the imaging where it might not fit the studies that were high volume, like in the charted study?
Right. So the definition for high volume and low volume are based on the charted, the Pioneer study. So to define the volume of the disease, I always try to get the baseline bone scan and CT scan, and also on top of that, PSMA PET scan, because some of the disease might not be able to capture with the bone scans, and then you kind of sort of have a sense. However, to define the volume, I still go back to the bone scans and CT scan to define, and then kind of define the, to make the decision for the treatment.
Absolutely. And I tell you, Travis, they call it a PSMA PET CT scan. So sometimes we go to the radiologist and say, can you look at the CT part of it? Because you can still pick up bone lesions there. But then we have these situations where, we always tell our, residents and fellows and say, okay, whenever you do a test, what does that test show? What are you going to do with that? So let's say that you have a quote unquote biochemical recurrence. Right, with conventional imaging, there's no areas of cancer, but then you have a PSMA PET scan, and let's say you have maybe 2 or 3 bone lesions or 2 or 3 lesions, quote unquote, oligometastatic, or maybe lymph node like N1 disease. How do you classify that in your practice, and how do you manage there?
I think it's challenging. I think this speaks to the importance of having lots of different docs of different specialties to run these cases by with tumor boards and things like that. PSMA PET's not perfect. It suggests cancer, I think based on CT correlate, based on size, based on how avid it is, based on if it sort of makes sense clinically with what you're seeing under the microscope on the biopsy, I think helps you make that decision. I think in the right circumstance, you trust what you see and you can treat and classify that patient's disease burden based on the PSMA PET. I think in other circumstances, you sort of approach that with more caution. And for whatever reason, choose to believe the conventional imaging instead.
Yeah, absolutely. And Ryan, I know that when you and I kind of talk, we always think about Gleason score, Gleason 5+4, 5+5, like Gleason grade group 5. But then you also have like the Gleason grade 3, and then you have these intermediate risks, like maybe they have a Gleason 4+3, so they're considered like a, unfavorable risk intermediate. And so whenever you see patients in your practice, we think about the PSMA PET scan and CT scan, but how does that factor into your treatment for the patient in front of you, like in terms of the Gleason score or the doubling time of the PSA? I know with the EMBARK study, they use less than 9 months versus more than 9 months. What are some things that you look in your practice?
So I prefer to get molecular imaging on everyone that's intermediate unfavorable and above, regardless of PSA or PSA doubling time. And it helps to categorize those patients especially when they're considering radiation therapy, for instance, in terms of how intense you want to be with their hormone therapy, in addition to possibly abiraterone. Also, it can impact the radiation planning, whether the lymph nodes are going to be included or an oligometastatic site within the pelvis. So I rely on it pretty heavily, and I don't always go back and get conventional imaging in that setting. If the spots are really small, you have the CT correlate with PSMA PET, but I don't go back and get a standard CT or a bone scan in that setting when they're really small and isolated in the pelvis.
Absolutely. And Vikas, when we think about those intermediate risk factors, PSA greater than 20, at least a Gleason of 8, or a T3C or something along that line, but let's say that you decide to do treatment, like for instance, for these patients that are localized, they did a single institutional study where based on the EMBARK study, 75 to 80% of those patients actually had metastatic cancer on PSMA PET scan. So what do you do typically on those patients that are quote unquote localized and they come to you for your patient and then you're thinking, okay, should I do treatment here? Should I consider them as, low volume metastatic hormone sensitive prostate cancer, or is this non-metastatic prostate cancer? How do you distinguish that?
It's definitely a difficult situation because all these trials used conventional imaging, and then you see a PSMA PET with 2 or 3 small lesions, and you're not
Yes.
sure what to do with that. But I mean, if you go by clinical trial data, I mean, that's what I typically do. So if someone doesn't have metastasis on their conventional imaging, I try to treat them as a localized disease. But then we have option to intensify systemic treatment, right? With Stampede data, we have Beratron that we could use for 2 years. And then when I'm picking the duration of ADT, I try to be on the higher side of 2 or 3 years rather than 6 months or 8 months. So we always play around, but there is no clear-cut data that this is how much duration of ADT or systemic therapy you're going to do.
Yeah, that's a great point. And you know, the Atlas study's taken forever, but that should eventually come out here soon.
Yeah.
That's also in that study group there. But you know, the other thing with the PSMA PET scan, Kumar, is the false positives. You know, we have these tumor boards, we have the radiologists, the SUV is greater than 10, they're convinced it's cancer. What do you do in your tumor boards for quote unquote PSMA positive, but you're convinced because of either the location that it might be a false positive? Any advice for people on that?
So it's all about pretest probability, right? So if you have a Gleason 3+3, and this is a patient we recently saw, you see a Gleason 3+3, but then you see a big sternal mass with PSMA is avid, right?
Yes.
So pretest probability is low for a Gleason 3+3, low PSA to metastasize already. So we do tend to biopsy that, and this is from a recent patient. It turned out to be a thyroid cancer.
Wow.
And now if you look at PSMA can be very, PSMA, is it called PSMA, but a lot of gut, your salivary gland, lacrimal glands can express its thyroid gland too. So I think it depends on your pretest probability. So when we are in doubt that, hey, we was not expecting this cancer to metastasize already, we do tend to biopsy, because for more and more we are using these PSMA PET scan, a lot of false positive is popping up. So for us, it's always pretest probability. If there's doubt, we do biopsy, because it does changes, right? So even oligometastatic prognosis changes, treatment changes. So we do biopsy if we are, not sure that this is a metastatic disease.
Yeah, that's a great point. I mean, something like this, we have to kind of think about, typically on the ribs, maybe not biopsy those, but like maybe the thyroid, or in the neck, you could have cervical ganglia that's false positive there, and none of us are going to put a needle in the nerve. So you're right, pretest probability. Anybody have any other thoughts on PSMA or molecular imaging? Have you noticed any difference between F18 versus gallium in terms of your practice?
I think from the medical oncology side, I haven't noticed a huge difference in my practice in either one. I think whatever one we can get the fastest and easiest is the one that I prefer. There's some data that suggests PYLARIFY is a little less noisy, and obviously there's some differences in production, like you mentioned, which I think on an institutional level matters. But in my clinic, I don't really tend to prefer one over the other.
Yes.
I'm taking a different approach to that question, pretest probability and when we use it. I also use genomic testing with the biopsy.
Yes.
So if I have a Gleason 3+3, but I have a really high risk genomic test, I think about sampling error with the biopsy. So that might also affect my reliability on the imaging.
Absolutely. Yeah, outstanding points. Vikas?
And
Yeah.
I was going to say that also the level of PSA also dictates the sensitivity of your PSMA PET scan. I mean, if you have PSA of 0.01 and then PSMA something is avid, then probably it's false positive.
Yeah.
So higher the PSA, definitely the sensitivity and specificity increases.
And that's a good point. In the original studies, the inclusion criteria was a PSA 0.2. But then with all of these patients that want to get this test, maybe they end up getting a test and then they have a PSA of 0.05. And then you have a positive lesion. Is that truly positive with a Gleason 6,
Exactly.
Absolutely.